Very good afternoon, everyone. Uh, do you know from where, which blood bank we order our blood? Navajivan Blood Bank. So this class today we are having of blood practices, which is going to be taken by Dr. Moni Udani. She is the owner of Navajivan Blood Bank. Okay, so I'll hand over to her. She'll give her introduction and then we'll start with the class.
Thank you very much, and a very good afternoon to all of you. It's a pleasure actually to take this lecture because I had taken it once in 2021 and it was really fun because we are dealing day to day but haven't actually met you people. So I'm feeling really good to meet you. And I have completed my MBBS from DY Patil Medical College and completed my MD in immunohematology and blood transfusion from MGM Medical College, Kamote. And now full time I'm working at Navjeevan Blood Bank and also I'm the owner of it. My father, Dr. Mukesh Udani, and now I'm running this because I also was very much fascinated and interested in blood banking basically. So I'll be I know most of you all are dealing with blood every day, day in, day out, and you must be knowing all the things. But yes, to brush up and yes, to avoid errors and mistakes, it's always better if you just have a good interactive session. So even you people can join in and we can have a good interactive session. But I'll try to just brief in that sometimes some errors happen. So we will try to basically eliminate errors from our end also and from your end also. We can just have a better knowledge maybe. So we'll just have a brief look at all the slides. And if any doubts, any difficulties, you can ask at any point. And after the session also, you can ask whatever doubts or difficulties you have regarding transfusion, right? Okay. So I'll be dealing about blood transfusion practices. So to start with, so steps in the clinical transfusion process. So okay, before I say, please you people say something. So how do you assess or how do you when you will try or order for blood or something? What would be the order? You let me know. Anyone, it's okay. You can tell just like what do you do? So if anyone wants blood, so what is the procedure? What you will do? Anyone? Okay. Okay. Right. Okay. Right. Right. Okay. Send the request and the blood samples. Okay, fine. So first thing I wanted to ask is that when do you label the sample? First thing I wanted to ask. When do you label the sample? Suppose you have decided that some person needs transfusion. So you are trying to take the sample. So when do you take the sample? So I wanted to know when do you take, because so then like I can accordingly tell you. So normally do you take the sample and then label, or you label the sample and then take the blood? That is what I want to ask. First you label it and then you take the blood. So yeah, so this was one very important thing I wanted to bring into your notice, that please try and first take the sample and then immediately label the sample. Because sometimes what happens is that we try, there are multiple patients you're looking after, and sometimes we label the sample, we keep it, and there is some another emergency, and if you go somewhere, there is some change in shift or something like that, because such errors have happened. Like when I was working at MGM hospital, so that time, obviously, you people are all experienced. But sometimes what happens is that you label the sample, you keep it, and then sometimes there is some mislabeling or misidentification of the patient, which may lead to error or which may lead to issues. So I would request you, first thing to do is take the sample immediately without any stoppage in your activity, label the sample, and then you start the process. That is one biggest request, because I know that normally it happens because we are trying, we are having multiple tubes, you label and then you go to patients and then you take blood and then you start your work. So first very important thing I wanted to request is that please take the sample first and then label, so it will avoid errors, avoid, eliminate misidentification or mislabeling. Okay, so in the steps of clinical transfusion process, there are three steps. First of all, assess the patient's clinical need for blood. so that according to the doctor, who is the visiting doctor, will decide whether which threshold or which hemoglobin level is very very important that you have to transfuse. Also, one very important thing I wanted to tell here is that it is always better to have or follow restrictive transfusion guidelines rather than liberal ones. Means, try and assess the patient until and unless in emergency, obviously, if there is a massive trauma, something like that, obstructive hemorrhage, then you cannot think about waiting. But in stuff like, there are many patients who are over transfused. Sometimes hemoglobin is 10 and they are transfusing. So I would also request for restrictive transfusion until and unless less than 9 gram is one of the threshold. Less than 9 gram hemoglobin and no other existing disease, less than 9 gram is the threshold, and less than 7 gram if in any case with any cardiac issues or existing cardiac diseases, it would be less than 7 grams. So do not over transfuse. Just do not try to, if 10 hemoglobin hai, we need to transfuse. No, it is not like that. So please assess the need and then you transfuse. Secondly, inform the patient and relatives about the proposed transfusion treatment. So basically, now all of you must be knowing and you must be taking informed consent form, because that is very, very important that the relatives are informed about the adverse effects of transfusion, if any, non-infectious or infectious. So you need to take informed consent from the patient's relative or the patient if the patient is conscious, right? Then select the blood product and the quantity required. That depends upon the level of hemoglobin or depends upon what is the platelet level, or if there is any bleeding tendency, you need to transfuse FFP or cryoprecipitate for any that. Complete the blood request form accurately. This is obviously very important for our convenience, because we have to confirm that this is the same patient for whom we are trying to issue. Then collect blood samples. So always you are supposed to collect 2 blood samples, one plain, one EDTA, because for cross matching and grouping we require this sample. And patient serum is very important. So for that we require the plain tube, because we need the serum for that. And for grouping we need EDTA. That is why we always, many times it happens that you cannot collect enough sample because maybe there is some massive hemorrhage or something like that. But we always request you to give these 2 samples so that we can do our compatibility testing at blood center. And then send blood request form and blood sample to the blood center. So I hope this is the procedure we are actually following all the time, right? Then, okay, so these are some things I just wanted to request you, that collection of blood by clinical staff, that is understood, that is done by either the nursing staff or the doctors. Don't store the blood in refrigerator. So in many times it happens that sometimes the order is that you issue the blood immediately, and we issue it and it comes, and then it is like, nahi, nahi, right now hemoglobin is okay, hemoglobin is normal, doctor says that nahi, nahi, we don't have to transfuse now. So then, for all practical purposes, once we issue blood, we can't take it back because of the cold chain breakage. So what happens? The doctor or nursing staff or anyone thinks that we'll store it in the fridge. Whenever it is required, we'll give it. But please do not do that, because blood, PRBC and whole blood per se, requires 2 to 6 degree temperature continuously. We are monitoring it and it is under alarm clock system. So those conditions are met in our blood bank, but in our domestic refrigerator, we don't have any control over the blood temperature. Neither do we know that what kind of temperature is maintained there. So just for that, please don't store the blood in refrigerator, because sometimes what happens, blood gets hemolyzed, something happens, the reaction comes, and it is like there is some transfusion reaction which is happening. But sometimes this is a mistake anyone can make. So I'm just requesting, never store the blood in refrigerator. Even if in any emergency, if you feel that now the doctor has said, like you called blood bank, you told issue the blood, and then you are telling that now we don't require, you can immediately call the blood bank and tell us that you don't want the blood. So we will stop it then and there. Even if the person is on the way, we will tell him to get back. And this happens many times, because this has happened. Sometimes the order is just, don't transfuse. So never store it. Platelets are always stored at room temperature. Okay. So platelets are stored between 22 to 24 degrees Celsius. at room temperature and with continuous agitation. So platelets also cannot be refrigerated in your domestic freezer, right? Because it will lose its viability. Right? FFP require very low temperature of about minus 30 degrees. So we are storing it in our deep freezers. So the take home message here is that please do not refrigerate any component which is issued from our blood bank to your hospital. If you have any issues, you can call us. You can communicate to us that you stop it, but do not store it at any domestic refrigerator, right? Not happening. Please, हो गया. वापस फ्रीज हो गया. एक ही मिनट, मैं देखती हूँ वापस. फर्स्ट स्लाइड हो गया, सेकंड स्लाइड हो गया. ओके, अभी हो रहा है. ओके, ठीक है, चलेगा. आई थिंक थर्ड साइड पे चाहिए ना, फोर्थ साइड पे चाहिए थोड़ा. हाँ, बस बस बस. ओके. So again, one very important thing that always check identity on patient, blood product, and patient's documentation. Please correlate everything. Monitor the patient before, during, and on completion of the transfusion. That you must be doing pulse, temperature, BP, everything, all vital signs to be monitored at all times, because there may be any transfusion reaction which may be allergic or maybe febrile reaction or maybe sometimes severe form also. So always monitor the patient, identify and respond immediately to any adverse effect or adverse event which takes place during transfusion, if during transfusion. Okay, next slide. Okay. So this is just that the request form, please fill it properly, especially the patient's name and identity and at least which ward or where the patient is, all those things, and otherwise all the other parameters, that who's collecting the blood and all. But I know that this does not happen very until and unless there is any NABH which happens. So because that is one thing. Chalo, next slide. Okay. So this is what I was telling in detail, little bit about the blood samples for compatibility testing. What you need to send is plain and EDTA, 5 ml for 1 to 2 units of cross matching, and if more than 2 units, then 10 ml of blood sample. Because we basically, whenever you are trying to reserve the blood or for the testing charges, so always we have to check it with multiple bags. Suppose if we need 4 bags, so we will need more sample for that. That is why sometimes there is an argument that you can't tell so much blood to be given because vein is difficult, this is difficult, but basically we need it for cross matching. That is why we are always requesting you for that. 2 ml for blood grouping, because blood grouping doesn't require a very large amount of sample. Label the sample clearly and accurately. Do not label the tube before obtaining the sample. That is what I told you first. And for further transfusion, send new blood sample for cross matching. Means any person's, any patient's blood which you are sending us for cross matching is okay till 3 days. Because normally after one blood unit is transfused, especially if in cases of any obstetric case, they may develop some auto antibodies or they may develop some allo antibodies after transfusion. That is the reason why we say that after 3 days of transfusion, if you require another blood bag, we will require a fresh new sample. That is because sometimes there are development of unexpected antibodies in the patient. That is the reason why we tell for the new sample. And obviously, if there is some hemolysis or something like that, so we will request for a new sample. Okay, next. Okay. So time limit for infusion. So basically, whenever the blood comes to your hospital, and then from then, when are you supposed to transfuse it? So obviously, red blood cells within 30 minutes, and platelet concentrates immediately, and FFP also within 30 minutes. So basically, as soon as possible, it is always better, because as and when the blood is out of the storage temperature, or any component for that matter is out of the storage guidelines, it starts to deteriorate, definitely. So that is why it is always better that we transfuse it is decided and we transfuse it immediately without any further delay. And it should ideally be over like the one bag, ideally it should be done within 1.5 to 2 hours, max to max. Sometimes if there is some reaction or something, or we are trying to introduce it, so we can just max to max 4 hours. But it should not happen that blood is issued in the morning and then the transfusion is happening in the evening, because again, obviously, as I said, there is something called as red cell storage lesions which may happen. Basically, even the red cell starts to deteriorate, and there are some lesions which happen in the blood cells itself. That is why sometimes it causes something like transfusion reaction, which we label as it as allergic, but it is something also due to damage to the red blood cells that we already were trying to infuse. And platelet concentrate and FFP within 30 to 60 minutes. Also, you must be knowing that red blood cell is a bigger bag, almost 250 to 300 ml, and your platelet concentrate is 50 to 70 ml, very small, and FFP around 150 to 250 ml. Obviously, if it is SDP, it is other way around, but RDP normally is 50 to 70 ml per pack. So obviously, it gets transfused also very fast. Next slide. Okay, I think this is everyone knows component. So basically, initially in the 1950s and 60s, it was all about whole blood transfusion. We used to do, matlab, anything used to happen. It was also all about whole blood transfusion only. That we used to give, collect blood from the donor and give entire whole blood to the patient. But after the advent of component therapy in the 1960s, now we are having component therapy. That is whole blood, which is divided into blood components, that is your PRBC, plasma, and platelet. So now we are having, and cryoprecipitate. So now we are having 4 components, and I would personally request, and I know most of us are giving PRBC transfusions only until and unless there is a massive hemorrhage or there is exchange transfusion. We are actually giving PRBC only, but PRBC use should be definitely much more encouraged and appreciated than the use of whole blood cells, because PRBC will help in, so the hematocrit value of PRBC is 70 to 80%. Of that of whole blood is only 30 to 40%. So if you want to actually increase the hemoglobin of the patient very quickly, then it is definitely better to instill PRBC rather than whole blood, because whole blood has platelet also, whole blood has FFP also. But due to the storage temperature, so okay, PRBC is stored between 2 to 6 degrees. Whole blood is also stored between 2 to 6 degrees. But whole blood has, along with PRBC, whole blood also has platelet as well as plasma, which will be deactivated as it is stored in the refrigerator of 2 to 6 degrees. So that platelet and plasma won't be important. Why whole blood was given? Because it was helping to maintain a good volume. That is why it is important in massive hemorrhage or any trauma case wherein you have to build the patient's blood volume. So in that case, whole blood is recommended. In exchange transfusion like of babies, again, whole blood is recommended. But otherwise, if any kind of anemia or any kind of trauma which leads to blood loss, if you want to increase the hemoglobin level of the patient, then pack red blood cell is the choice or is the mainstay of treatment. Clear? So basically, this was about components, and components are divided into red cell concentrate, platelet, FFP, cryoprecipitate. Next slide. This is just to show that this is a blood bag and then how it is divided into various components: packed red cell, platelet, and FFP. And whenever required, we are making cryoprecipitate out of it in cases of von Willebrand disease or factor 12 deficiency or Christmas disease, all congenital disease basically, where you require cryoprecipitate. Next slide. Okay, so this is just to introduce again about whole blood. So whole blood is basically 350 or 450 ml bag, whichever we take, which has 49 to 63 ml of anticoagulant in it. And the hematocrit is 36 to 44%. No components are removed. I said whole blood is as a whole. You are taking it from the donor and entire bag. You are not separating. You are not making any component out of it. It is an entire whole blood bag. stored at 2 to 6 degrees. And shelf life. Okay, so there are various different anticoagulants and there are different shelf life. Normally, we are using CPDA or Sagum bag, which has a shelf life of 35 or 42 days, depending on the component we are preparing. So if we are preparing platelet, FFP, and blood, then we are normally using CPDA bags, and Sagum bags are usually used for platelet and PRBC and FFP. So normally we are having the bags of 35 and 42 days expiry. Next. Indications, I already discussed that indications of using whole blood cell, a whole blood bag is acute blood loss with hypovolemia, where you are actually trying to increase the volume. And secondly is exchange transfusion. Otherwise, no other indication for whole blood. Next. Pack red cells. Okay. So pack red cells is the most utilized component in our hospital also, because maximum patients need it, maybe pre-delivery or many cases basically. So the storage temperature is 2 to 6 degrees, 35 days is the shelf life. And as I said, the range, the PCV, that is the packed cell volume or hematocrit, is almost about 80%. 65 to 80% being the average, which in whole blood was only 35 to 40%. Here it is 65 to 80%. So the value and the hemoglobin uh, raised would be much better and more in cases of packed red blood cell. And the content is 65 to 80% red cell and 20 to 30% of plasma. Next. Now platelet concentrate. So platelet concentrate shelf life is 5 days. In platelet incubator and agitator, I told you that it requires constant agitation. Otherwise, they come and aggregate. So that is why they are agitated continuously. And the storage temperature is 20 to 24 degrees. That is our room temperature. So we cannot refrigerate the platelets at any cost, right? And the QC requirement. So basically, this is for us actually. That it has to be prepared within 6 hours of collection, that is from the donor. Whenever we collect within 6 hours, we have to prepare platelet, and the pH should be more than 6.2, volume should be between 50 to 70 ml, and content of platelet at least this much, so that it can raise a specific a platelet level in the patient also. Next. Single donor platelets. So single donor platelets, so you must be knowing the difference between RDP and SDP. RDP is random donor platelet. SDP is single donor platelet. RDP basically bags are small volume and taken from different donors. So basically 1 dose of RDP is equal to 6 bags. So that will, but that would be 1 SDP is equal to 6 RDPs. So if you are giving 1 SDP, so it will be equivalent to 6 RDPs what we give, right? 6 to 8 times more platelet as in a random donor platelet. So basically, if you take 1 bag of RDP and you transfuse to the patient, it will increase the platelet by 5,000. But similarly, if basically our requirements normally in dengue patients, wherein the platelet counts are below 10,000, when we actually want it has to be above 50,000. So that time you actually need to give SDP. And SDP has much more. SDP almost increases about 20 to 30,000 in one go. So that is how. And also one more advantage of SDP is that basically it is from single donor. So risk of infectious transfusion would be definitely lower. Okay. And again, ABO matched platelet would be preferred if you are trying to give SDP. So it is a large volume. So definitely ABO matched platelets would be given, and that would be preferred. Next slide. Okay, a little difference between RDP and SDP. So basically, RDP is prepared from whole blood donation from donor which we collect, that is whole blood donation. But SDP is via platelet apheresis technique. Okay, then yield of or definitely of SDP is much more high. Plasma volume is also much more high in SDP. RBC contamination in SDP would be minimal, because it is all automatic via the apheresis machine, and definitely there is minimum RBC loss. Then expose this patient to only single donor, SDP, and decreased risk of contamination in SDP. Next. Okay, fresh frozen plasma. So again, fresh frozen plasma can be either collected by the donor directly or by plasmapheresis. And it has all the plasma proteins like factor 8, factor 9, fibrinogen, and the volume of FFP is around 200 to 250 ml. And shelf life of FFP is 1 year. Okay, it can be stored for 1 year, but it requires very, very low temperature, that is minus 30 degrees Celsius. Okay, next. What are the indications of fresh frozen plasma? So definitely if there is any active bleeding, it is definitely required. If any coagulation factor deficiencies in liver diseases, especially like cirrhosis of liver, DIC, disseminated intravascular coagulation, any coagulopathy in massive transfusion, or TTP. Cryoprecipitate. So cryoprecipitate also, again, the shelf life is 1 year, and it is also frozen minus 20 degrees or 30 degrees or more, and the volume is very, very low, that is 10 to 20 ml. And normally it is required in congenital deficiency like factor 8 deficiency, factor 12 deficiency, factor 9 deficiency, von Willebrand diseases. It is not very much used, but yes, definitely in congenital diseases it is definitely used, where there is issue in secreting the factors naturally. Next. So indications: DIC, hemophilia A, von Willebrand disease, factor 12 deficiency, uremic coagulopathy. Next. Okay. This is again very, very important. Dose of blood components. So basically any pack red blood cell, 1 unit of pack red blood cell will increase hemoglobin by 1 gram% and hematocrit by 3%. So basically if you are trying to see or maybe wanting to know or study, so basically it always 1 unit will raise 1 gram% of hemoglobin. Then platelet, 5 to 6 RDP or 1 SDP is a single dose. Basically, one dose of platelet is 5 to 6 RDPs or 1 SDP, and basically it should increase the platelet count by 30 to 50,000. And platelet transfusion also should be avoided as much as possible until unless there is any active bleeding tendency or real emergency situation. Sometimes it is transfused, it was not needed, but it was transfused. It had happened once. So please see that. FFP, 4 units per 4 units in the adult is the dose. And cryoprecipitate depends upon the body weight. But normally one dose of cryoprecipitate is 10 units, because cryoprecipitate is only 10 to 20 ml in one bag, basically. So 10 units is the ideal dose. So ideal dose is 1 unit, 6 units, 4 units, and 10 units. These are the normal doses of blood. Next. Okay. So storage, I think I told you, but you can just go through once. That red cell and whole blood 2 to 6 degrees, platelet 20 to 24 degrees, and fresh frozen plasma minus 30 degrees. These are the storage temperatures. Okay. So checking the blood bag. So yeah, this happens, the checking happens also at our end. In our blood center also, we have to check before we issue the blood. We have to check for signs of any deterioration or hemolysis or any kind of damage, basically. And also it has to be checked by you before you transfuse, because we have to take care. Ultimately, we are here to save the patient, to serve the patient. So it is issued in the blood bank. Before that, we have to check it for any physical damage or any color change which sometimes may happen or occur. Then on arrival in ward or OT, and before transfusion if it is not used immediately. Next. Checking for signs of deterioration. So basically what you will check. So any signs of hemolysis in the plasma, then any signs of hemolysis between RBCs or plasma, any signs of contamination. Sometimes it just doesn't appear properly. Like sometimes you may feel that the color of the blood is changed. So once when I was doing my MD in MGM hospital, so once it had happened that the whole blood bag was normal. Matlab, it was dark maroon, red, whatever, the normal color of your blood bag. But only the segment which is attached to the bag was blue in color. It was totally blue. So bright blue. Matlab, anyone can see it that it was totally bright blue in color, and the bag was absolutely normal. And then it happened to be that there was some contamination while the patient was transfused. Maybe they had used something else also to transfuse, and some color change occurred in the segment. So the bright blue segment with a red bag. So always check everything, because sometimes there may be some contamination also. There may be some other, basically with other IV line, if you are trying to infuse blood also and some other medicine also, sometimes that reaction also, but it happens. So please look into that. So any color change or anything like that, any clots, this happens many times, that if sometimes while donation, if we had taken the blood, but it was sometimes the flow is slow, or maybe the vein punctured was not very prominent. So sometimes it happens that there are clot formations, and it has happened in our case. So we have obviously replaced the blood bag, but please watch for that, any clot formation, anything, or any damage or any physical leak in the product. So all these things are to be observed by us also, and by you also before transfusion. Next. Okay. So this is basically that, only to see that if there are any. So because the blood bag has red cells, plasma, and these are the segment attached to it, and the for attaching your IV line access and everything. So please look for any hemolysis, anything between red cell or plasma, for any large clots, any color change, any leaks. If so, you have to watch for everything, right? Next. Okay. Transfusion protocol. So assure that the patient's IV line is well secured, and then send the issue request form in the blood bank first and foremost. In cases where the units are always reserved, already reserved, then check the patient's identity and the blood product before transfusion. Okay, one year, very important point I wanted to say is check the patient's identification, identity. So there you always please do the positive patient identification. Never ask the patient leading questions, that are you this, are you that. Like you have to properly ask what is your name and everything, because sometimes they will reply yes to everything and anything, the relative also and patient also. So please, positive patient identification is very, very important. Ask what is your name, and don't ask is your name this, because normally they tend to give answers yes to everything. So positive patient identification one is very, very important. The final check at the patient's bedside by registered nurse or doctor is mandatory to detect any identification error or prevent any potentially incompatible transfusion. So basically, before transfusion, you are supposed to check the blood bag, the blood group of the patient. Along with that, also please check the compatibility report, cross match report, which is given to you along with that. So you can just check it once, that the compatibility report, the patient and the blood group of the patient, everything is matching. So there is no potential issue which may happen, or error which may happen. Next, please. Okay, so rate of transfusion. So basically, in routine cases, whenever you are trying to transfuse, always there is, as you must be knowing, that for any medication we are going to give a test dose, right? Because we want to see that the patient does not have any reaction, like in any medication. So basically, even in transfusion, for the first 15 minutes, 2 ml per minute, that is around 40 drops per minute, and then slowly, gradually, you can increase it and go up to 80 drops per minute, that you can evaluate. But you should always, so there are five times you are supposed to monitor the patient: before transfusion, after transfusion 15 minutes, then after half an hour, then after 45 minutes, then after 1 hour, and then after completion of the transfusion. All the vitals to be monitored, because at any point of time, if there is any reaction, any adverse transfusion reaction, you can immediately report. And never ever warm the blood bag. It can lead to hemolysis. Definitely in cases of some massive transfusion, or otherwise in exchange transfusion, or any special cases, you may use the blood warmer. But in routine cases, please do not warm the blood. Next. Okay. Risk of bacterial proliferation or loss of function in blood products once they have been removed from the standard storage condition. That I already told you, that as you are removing it from the storage, definitely it will start deteriorating. All the components should be completed within 4 hours of removal from the refrigerator. If any IV fluid other than normal saline has to be given at the same time as you are giving blood component, it should be given through a different or separate IV line. Please do not mix two things together. Always give it separately. And even components for that matter. If you are planning to give a patient FFP and you are planning to give patient PRC also, so please do not give it together. Why? Reason being that sometimes you are if you get a transfusion reaction, you will not be able to know that basically it was due to what. So that is what very important thing. And maximum transfusion reactions or allergic reactions which we get are basically from FFP. Maximum, huh? Matlab PRBC and platelet goes down, but FFP allergic reactions are very, very common. Next, please. Warming blood, I already told you that it is not required, but in selected cases it may be required, like large volume rapid transfusion if you are actually transfusing a lot of blood, massive transfusion protocol, exchange transfusion in infants, and if patients are having clinically significant cold agglutinins. If they are having any cold antibodies or cold autoagglutinins, then definitely you are supposed to, you may have to give warm blood. Madam, ये change कर दो. हाँ. Okay. So instruction for using blood transfusion set: change the blood administration set after 4 units or 12 hourly, whichever is earlier. Okay. More than 12 hours, do not use the same BT set, but otherwise use different BT set for different components. So if you are giving PRBC different, FFP different, platelet different. The unit should not be transfused if the unit has been out of the refrigerator for longer than 30 minutes, or if there is any sign of leak, or if the red cells look different in color. Next. Okay, so monitoring the transfused patient. So basically, first thing is, I told you the 5 stages. When are you supposed to monitor? The stages for monitoring. Before starting transfusion, as long as transfusion is started, 15 minutes after starting transfusion, then after completion of transfusion, and then 1 hour after transfusion. Because sometimes there are delayed transfusion reactions also. That is why. Okay. Then clinical parameters. So basically, you are supposed to see the general appearance of the patient, temperature, pulse, BP, respiratory rate, vitals. Basically, you are supposed to monitor fluid balance, urine output. You are supposed to see all of these. I know you people are much better in that. Record. So basically, this is also one very important thing, that when it was started, when it was completed, how much was transfused, what kind of blood product was transfused, and if there was any adverse effect or not. So all these things are basically to monitor a particular transfusion patient who has been given transfusion. Okay. Just to touch upon adverse effects of transfusion. So basically, what is a definition of adverse effect of transfusion? An undesirable and unintended response to the administration of blood component, or plasma that is definitely or possibly related to them. Because otherwise, whenever you are giving transfusion to the patient, obviously first you are monitoring the patient, you are seeing it, he does not have any fever or something like that, and then only you are planning to transfuse. You will not transfuse anyone who's febrile. So basically, whenever you are after the administration of blood product, if you are seeing some changes, so definitely that is one event which is called as adverse transfusion reaction. They're classified into 2 types: acute and delayed. So basically, acute is symptoms which will appear within 24 hours, and delayed sometimes that would be even after 24 hours of administration of blood products. Next. So how would you just categorize it? So mild, many times it happens that there is some mild rashes coming up, or there is some itching. and hypersensitivity reaction is basically the cause due to it. So basically, allergic transfusion reaction, which we can label, and it is very, very common in cases of FFP transfusion because of plasma. Then moderate, basically, if he's having fevers, rigor, flushing, urticaria, tachycardia, so definitely we will categorize into moderate reaction, and symptoms may be anxiety, pruritus, palpitation, dyspnea, headache. It may be due to FNHTR, that is febrile non-hemolytic transfusion reaction in many. Mostly the reactions what are reported so far are febrile non-hemolytic transfusion reaction and allergic transfusion reaction. Major complications, touch wood, by God's grace, we have not reported, and we don't want also any major reaction. But these two are most common, which we often come across. So always stop the transfusion, start with Evil Hydrocort, monitor the patient, other, and stop the transfusion. Don't give, because maybe till that time we can work up, you can send the samples, and then we can let you know. But for that day, you can just stop it. Next. Life threatening, obviously. So that is always very difficult to manage, because something like trally or bacterial contamination, if any, which does not happen, but if it happens, it is obviously a very big medical emergency. So these are some of the symptoms may occur: anxiety, chest pain, respiratory distress. That time may be due to trally transfusion related acute lung injury. But we hope and we never want to get such kinds of reaction. Next. Delayed complications. So delayed complications also, so basically immune mediated and non-immune mediated. So basically immune mediated are all like graft versus host disease, transfusion related graft versus host, hemolytic reaction, sometimes alloimmunization, which may occur after repeated transfusions maybe, and some infectious reactions also, I mean, infectious diseases also may be sometimes, because if the patient or the donor was in the window period and maybe we transfused it that time. So HIV, HBsAg, HCV, those are all some of the reactions which we may come across. Next. If acute transfusion reaction occurs, check the blood bank labels, patient's identity. If any discrepancy, stop the transfusion immediately and inform the blood center. Next. Investigating, so basically immediately report it to us, record it, what was the type of transfusion, the length of the time of the reaction, when it all this happens, because normally this is very much streamlined, because we immediately get the requests and we try to get back as soon as possible within 24 hours. But basically you have to give all the details: volume, type, pack, length of the time, and then also along with that you can send your samples also, pre-transfusion samples also, and post-transfusion. Pre-transfusion samples we will already have, because we are cross-matching and giving it to you. But post-transfusion samples also we require to actually get back and to know the discrepancy which any of after testing the compatibility testing, cross-matching blood grouping, we need to check that. And first pass urine sample post-transfusion, because in case of any hemolysis or something, we need to actually give a transfusion workup for that. Next. Okay, so this I already told you, and I think you people are actually way more better in this actually, to manage the patient. Slow the transfusion, stop the transfusion, administer the antihistaminic, and if no, then you treat it as category 2. So this is category 1 mild. Slow the transfusion or stop the transfusion, administer antihistaminic. If no clinical improvement within 30 minutes, and if it worsens, then treat it as category 2. Next. Stop the transfusion, notify the doctor responsible for the patient and the blood bank immediately, administer antihistaminic, administer antipyretic if there is any febrile reaction. In thrombocytopenic patient, always avoid aspirin, but immediately try and mobilize everyone along with the blood center, also your notifying doctor. Next. Give corticosteroids if required. If there is any anaphylactic features, you may have to give bronchodilators. And if clinical improvement is there, then again you can start up with the transfusion. But if not, then treat it as category 3. Next. Life threatening. So definitely stop the transfusion, notify the doctor, infuse normal saline to maintain the systolic BP, maintain airway, breathing, circulation, everything. Give adrenaline by slow intramuscular injections. basically treat it as a life-threatening emergency. So everyone has to be mobilized immediately. Next. Next. Okay. So basically, if you are so if there is any reaction which has very high grade fever, which is after FNHTR, that is febrile non-hemolytic transfusion reaction, the fever will settle down as soon within 24 hours or so. But then again, if you are suspecting that there is a high fever, 102, 103, it is not settling by any which way. So maybe there may be issue with the blood product which may be contaminated, and that you have to take care, so that you will start up with your IV antibiotics, and you will start the broad spectrum antibiotics and all of that. Next. In emergency, yeah. Okay. So if there is any emergency, that time, if there is absolute emergency, we can issue O negative PRBC at any. Thank you. We can issue O negative PRBC if there is no availability of the blood right there, or if there is no time for cross match and we can't do cross match, we don't have the blood group of the patient, then definitely in emergency situation, if the treating doctor sends us the requisition regarding it, then we can definitely, in life saving circumstances, always can issue O negative PRBC, but it has to be with the requisition and also the informed consent, with the discussion with the relatives. But O negative PRBC can be issued, and if you know the patient is Rh positive by any chance, then ORH positive also can be issued to the patient. So ORH positive if you know the RH status, or O negative if you know. If you don't know and it is absolutely in an emergency situation, you may issue O negative blood. Okay. Yeah. So O negative, O positive. Yes. Next. Okay. So just to, obviously you must be knowing, but O negative, because of, if you don't know about the RH status, then O negative you have to give. If you know about the RH status that it is ORH positive, then you can give O negative packed cells or O positive packed cells. Universal plasma is AB, because AB plasma has no antibodies, because it has A and B components, so it is has no antibodies. Anti-A, anti-B antibodies are not there. So you can always give AB plasma if you don't know, and you can give O negative or O positive depending upon the RH status. Also, if there is any emergency like that, O negative patient, if the patient is in absolute situation where he could not survive, and O negative is also again very, very rare. You don't get negative group as much. In our stock also, we may be having 1 or 2 bags, which may be reserved also. So in such emergency situations also, maybe for once, you can transfuse O positive if it is definitely beneficial to the patient to save his life. Because if you transfuse O positive to O negative once, there will be no issue. Second time, if you are trying to transfuse, definitely there will be reaction, because that is the first time exposure to the patient. So they will still take time to produce some antibodies. But second time, definitely you can't give, but that is in a very, very rare case. But this is just if you have to save the patient at that time, then you can give positive. It has also been notified. So basically, I was also not very confident to say this, because even though being in the blood bank, I am also a little resistant, because these days patients also create a big chaos. But right now, in guidelines of December 2022, good blood bank practices manual by Government of India, they have released the statement: Rh positive can be given to Rh negative patient in cases of life saving situation. Otherwise, he may not survive, he or she may not survive. So in those cases, you can transfuse positive to negative, but in very, very rare cases. Next. So basically, my take-home message would be: evaluate and transfuse. Never prefer or perform warming of blood. Always assess the risk and benefits of transfusion. In emergency, please consider O negative, and if you know RH status, then O positive RBCs. And always the request of from the clinician to be given for this. These are my references for today's presentation. Thank you so much. Hmm. Yeah. I would still suggest to give it directly from the peripheral line and not give it. Huh.
Hello.
Huh. No, no. Collect. Yes, collect, please.
So my question was actually, I had given a scenario to ma'am stating that like in case if a patient is there who is having a central line and the doctor is advised for a cross match. So in that case, like how we have to take the sample, whether we can take it directly from the central line or it is like we have to take it from the veins. So
I would really request if it is possible, then give it directly from the peripheral line only. Don't disturb the central line also for that matter. Also don't. We don't want to even introduce any kind of infection again for that. And also otherwise for compatibility testing, it is always better if we have a fresh blood sample
unless
from.
and until like if a patient we are not getting the veins.
Yeah, then
that
in
case,
such
it is
cases,
okay.
yes, definitely. But my request would be still.
And ma'am, one more question.
Yeah.
So you said the shelf life of the blood cells is like around 42 days.
Yes.
The packed blood cells
Yes.
and all. What you keep it in the
Yes.
freezer.
Yes.
So in case like the 42 days have got over, now if itna blood the balance is there. Now what exactly you people
We
do
have
with
to
it?
discard it.
You are discarding it.
But we don't face such situation because the requisition and everything, we are actually out of stock all the time. So
Okay,
normally
it has never happened
it
from
has
your side.
maybe one or two cases sometimes a platelet discard happens because platelet shelf life is only 5 days. So platelet discard happens quite a lot, but RBC discard we try and manage that, we issue it within the time period within 20-30 days only, because we don't want to waste such a precious resource, because donation also is a very big, voluntary donation itself is a very big. So normally we are not wasting any RBCs. Platelet happens, but RBCs no. We are normally issuing it within the time frame.
And my one more question, like
Yeah,
in
yeah.
case if the electricity is gone,
Okay.
you have the inverter
Yes.
or the generator.
Yes.
So it will work for around 7 to 8 hours or maximum 10 hours.
Yes.
Current नहीं आता है full.
नहीं, but ऐसा है ही नहीं हमारा पूरा always it is गया भी तो immediately within a fraction of like 15 seconds आ जाता है current backup generator supply के हिसाब से.
If it happens like that, then in that
then it has
storage,
to be shifted. Then it has to be
so you
shifted.
can't see like you can't wait it for 1-2 hours.
So
like
yeah, that much we can wait, definitely. That
Because
much like
nowadays the freezers are like a green label one where it is
I
like
know,
0%
I know.
UV.
That much we can wait, but ऐसा तो हुआ ही नहीं है. होता है, power cut होता है तो भी within 15-20 seconds it has to be done, and we have a generator backup and everything. तो ऐसा होता नहीं है, but अगर ऐसा होता है तो we have to definitely shift it, because otherwise we will damage the blood products, blood components. Anything else? Yeah, please. Huh. Up to 12 hours, not more than that.
No,
So
actually we are using means we are single use only we are using it.
okay,
actually.
okay.
Okay. Then one more thing, about leuko-reduced blood and blood set you have not discussed.
So basically, we are not supplying loco-reduced blood. We
Okay.
are supplying you filters, and we are
Okay.
doing bedside filtration.
Okay.
So that is the reason why I didn't.
Okay.
Yeah, mention that, because we are
Filters.
not doing leukoreduction basically.
And
Yes, please.
Now, we have already mentioned that we should put an IV cannula of 20 gauge,
Yes.
right? What if the patient already has a 24 gauge, especially in chemotherapy, 22? In case of chemotherapy patients, basically.
That is okay. That is. I have just,
hemolysis होता है क्या कुछ?
हो सकता है, इसके लिए white board थोड़ा सा भी
हाँ,
tell
so
हो सकता है, definitely.
preferably it should be 20,
yes,
no?
To avoid hemolysis only.
During blood transfusion, अगर patient को fever आया,
हाँ जी.
that time doctor sometimes they will tell ना you wait for some time,
Yes.
then we will start.
Yes.
If we are waiting for 1 or 2 hours,
Yes.
what will be the condition of the blood?
So basically, we should ideally then stop it only, because 1-2 hours. So again, basically up to 4 hours you can wait, not
Mhm.
more than that. That is what
Okay.
I mentioned, max 4 hours.
That is an
Not
open blood.
yes,
Means that is already
that is
open.
going on and then you have stopped it. No,
Uh-huh.
it I would request that don't let such situation come, but if it comes, you can for up to 4 hours, not more than that, because otherwise also when you are
In the room
transfusing.
temperature only we can keep.
Yes,
Because it
yes,
is already hanging, that we
yes,
can
yes,
keep
yes,
like that
yes,
only.
up to 4
Okay.
hours is okay, not more than that then.
Okay.
Because otherwise also in thalassemia patients or something like that, when we are transfusing, sometimes it takes time for the transfusion to get over, so that is why there is a higher limit of 4 hours, but not more than that then.
Okay.
Yeah. Yes, definitely it is, but very rare. So it comes one in maybe 2 years or 3 years. But yes, yes, it because the people who are लेता है मतलब बॉम्बे को बॉम्बे ही देना पड़ता है ना, बॉम्बे को बॉम्बे ही देना पड़ता है. Nothing, nowhere, nothing. Bombay blood group will always require Bombay blood group only.
Yeah, can you just explain what is that Bombay blood group? I'm not sure everybody is aware of it.
So basically, it was discovered in Bombay. That is why it was given the name Bombay blood group. And what happens is that basically, when you are trying to, so there are H antigens which are present otherwise, and if those H antigens are not present, those people will not be able to react with the anti-H serum. That is how we come to know that they are Bombay blood group. Otherwise, if you try, so basically they appear to be like O, group O, but they are not going to react with anti-H serum, which is present. And that is very rare blood group. So only maybe 45 to 50 people may be present all over. Once in 2 or 3 years, we are getting such kind of a bag. And it is very rare because only they can be transfusing to the another person. Otherwise, मतलब only Bombay to Bombay, O negative, O positive, A B कुछ नहीं चलेगा. Bombay को Bombay ही चलेगा. That is basically the difference in the antigenic surface of their blood cell. That is the main difference between O and Bombay blood.
Then we can use the other food.
Other body, yes. So, नहीं, मतलब I am telling you that whenever you are transfusing, you try to not give anything else. Ideally, try not to give anything else when you are transfusing blood for some time. You can give normal saline, etc., but don't give anything else for that patient until and unless it is possible for your end. No, nothing. Only I am telling only normal saline. I am even telling you that don't even transfuse another component also. FFP, platelet, cryo, kuch mat do when you are transfusing one particular component. That actually depends upon what is the clinical scenario and what the patient actually needs. That is so definitely your right. I would request first to give blood, then give FFP. And from a separate this only, separate set, separate administration set, and give blood first, give FFP later, because FFP as in वो -30 से वो आया है तुम्हारे पास, and then it is still manageable, but blood पहले दो. Always give PRBC first.
One line, it's only blood transfusion. So because dopamine, dopamine, everything
Is
should
going
be,
on.
yeah.
That is fine. That time you can, matlab. Yes.
Any doubts? Any questions?
in case of MTP or something, not more than that.
No more doubts?
If anytime anyone has any doubts, any difficulties, any issues with the blood bank, or anything you want to communicate, feel free to communicate anytime, anyone. Huh? I am Dr. Moni Udani. Anytime you can communicate to me. You can take my number and you can actually communicate to me if you have any issues anytime. We are always very, very happy to help.
Just a minute.
Okay, sure. Sure, we'll do that. We'll do that. We'll do that. On emergency basis, I'll get it done. Actually, I was going to get it done because there was some requirement in some camp, particularly they wanted IDs. I will do that. Yes.
Thank you so much, ma'am, for
Thank
giving
you.
your valuable time and such a powerful information to us. I'll declare the session is ended now. Thank you, ma'am.
Thank you so much. I would like to thank Bethany Hospital. I would like to thank Sneha Madam. I would like to thank all of you that you took out your precious time and came for my lecture. And I hope that it would help you and we will communicate and be in better touch. But thank you very much for coming. Thank you.